So POPS stands for Proactive Care of Older People Undergoing Surgery. It's a multidisciplinary service which is really looking at assessing and then optimising older complex patients prior to both elective and emergency surgery. And then the team that provides that service following the patient through their surgical journey, looking at managing the medical complications that occur, the rehabilitation and the discharge, so that we can ensure that patients are as fit as possible when they come in for their surgery and then are as fit as possible when they leave hospital after the surgical episode. So the very immediate opportunities have been around our registrars who've been starting to deliver on the programme at Dartford Valley, for them to learn about establishing new services at a district general hospital, looking at translating the lessons that we've learnt at a teaching hospital and moving that out to the district general hospital. So alongside that, they've been learning about leadership, service development and service delivery and all of the challenges that come around embedding new services at a hospital. The other opportunities have really been very much more on a general workforce basis at Dartford Valley. By doing this work, we're finding that we're upskilling the existing staff there to be able to identify and manage issues in older people better than they were able to previously. And that education and training program's really been focusing on surgeons, anaesthetists and particularly the ward nursing staff, so that we're upskilling them as well. And then thirdly, the program's really afforded us with new opportunities, such as applying for a Dhesi fellowship, to be looking at evaluating the service that we're now embedding at Dartford Valley, evaluating the education and training programme, and then also looking at developing new educational opportunities for trainees as they start to come through the system. So I think there's probably three different things that we'd want to be looking at if we want to recreate POPs around Dartford Valley and also further afield. The first thing is that we're pretty clear that this requires strong leadership. It also requires the appropriate local workforce to deliver on that, and that means that we have to have people who are trained up in perioperative medicine alongside geriatric medicine. And we need to think about how we're going to educate and train the workforce to be able to deliver on that and develop an adequate workforce to be able to set up similar services. And then that leads into the third challenge, which is very much around funding of such services. This is a very new way of providing collaborative care in an integrated fashion. And it does require prime funding to get the service up and going before we can start to see the cost savings that we can achieve through such models. So probably those three things I think are pretty key to being able to establish these types of services. So I think the primary benefit is very much for patients. This has been very much about trying to develop local services for patients so that they're not having to come up to teaching hospitals for multiple appointments. And particularly for the older group who often have multimorbidity, we're trying to make sure that they're seeing one specialist who has skills around managing multimorbidity rather than going to various different organ specialists who may not be able to understand exactly how each of those conditions affect each other and affect the perioperative period. We are also starting to see benefits in terms of clinician reported outcomes, so starting to see reductions in morbidity and looking then to see if there are effects on mortality, but more so also on the quality of care delivered in hospital, which we'll be measuring looking at rates of falls, delirium, those kinds of things as well. The benefits we think will be very much around the processes, looking at reducing multiple appointments, reducing length of stay, and hopefully then looking to see whether we can reduce readmissions as well as a consequence of that. And additional cost savings around reduced transport costs, the interface between primary and secondary care, and ensuring better information flow between different services.